Hello, my name is Dr. Ann So, and I'm a professor in the Department of Thoracic Head and Neck Medical Oncology at MD Anderson Cancer Center, and I am the director of the mesothelioma program and director of the thoracic chemoradiation program. The purpose of this podcast is to highlight a change in standard practice in the local regionally advanced non-small cell lung cancer setting. Prior to the era of immunotherapy, patients with unresectable local regionally advanced non-small cell lung cancer were treated with concurrent chemoradiation. The reason for this was that all local regionally advanced unresectable non-small cell lung cancer trials showed that concurrent chemoradiation was superior to sequential therapy or radiation alone, and no randomized studies ever demonstrated a survival benefit with consolidation chemotherapy, nor even consolidation or maintenance targeted therapy in an unselected population. Therefore, concurrent chemoradiation using weekly low-dose platinum taxane or a platinum doublet with etoposide or pemetrexed was accepted as a standard of care until 2018. The Pacific trial has now changed our standard of care for local regionally advanced non-small cell lung cancer with the use of durvalumab consolidation. This was approved in February of 2018. The Phase 3 International Pacific trial, published in the New England Journal of Medicine, enrolled 713 local regionally advanced stage 3 non-small cell lung cancer patients and randomized them 2-to-1 to 1 year of consolidation durvalumab, a PD-L1 inhibitor, versus placebo. Durvalumab or placebo was given on days 1 to 42 after definitive chemoradiation therapy. At a median follow-up time of 15.2 months, the durvalumab arm showed a superior overall survival benefit with a hazard ratio of 0.68 and a p-value statistically significant at 0.0025, and a 24-month overall survival rate of 60.3% in the durvalumab arm versus 55.6% in the placebo arm. The p-value here was also statistically significant at 0.005. The progression-free survival favored the durvalumab arm with a median PFS of 17.2 months compared to 5.6 months in the placebo arm, for a hazard ratio of 0.51. Durvalumab also prolonged the median time to death or distant metastases at 28.3 months versus 16.2 months, for a hazard ratio of 0.53. In terms of safety and toxicity, there were more treatment discontinuations that occurred with durvalumab at 15.4% versus placebo at 9.8%. Pneumonitis was the most frequent cause of treatment discontinuation, with a 6.3% rate in the durvalumab arm versus 4.3% in the placebo arm. As anticipated, immune-mediated toxicities occurred more often with durvalumab compared to placebo. For any grade, it was 24.2% in durvalumab arm versus 8.1% in the placebo arm. Grade 3-4 toxicity occurred 3.4% in the durvalumab arm versus 2.6% in the placebo arm. Durvalumab-treated patients had a higher rate of use of glucocorticoids, 14.3% versus 5.6% in the placebo arm. There was more endocrine therapy as well in the durvalumab arm at 10.7% versus 1.3%. Based on these results, the Pacific trial has reshaped the stage 3 treatment paradigm, and it should be expected that this is now the standard of care, where patients who are treated with concurrent chemoradiation should receive consolidation immunotherapy if they are eligible for an immunotherapy agent. Typically, we continue the durvalumab for 1 full year after concurrent chemoradiation. There has been a lot of discussion about biomarkers and identifying which patients should derive the most benefit from this year of consolidation immunotherapy. As of today, this still remains a research question. In the Pacific trial, baseline tissue collection prior to chemoradiation was optional, and PD-L1 immunohistochemistry was only successfully performed on 63% of the patients. The PD-L1 immunohistochemistry cutoff was also a little bit different. The cutoff was determined to be less than or greater than equal to 25%. Based off of this cutoff, durvalumab did appear to provide a progression-free survival benefit across all PD-L1 immunohistochemistry expressing patients. However, it should be noted that the Pacific trial did not report data on the PD-L1 IHC 0 or negative patients, nor was tumor mutation burden evaluated, nor was genetic sequencing by next-generation sequencing performed on the patients during enrollment on the trial. In the United States, it is not currently recommended to use PD-L1 IHC nor TMB to determine eligibility for durvalumab consolidation. However, in Europe, surprisingly, it was decided to only approve use of durvalumab in patients who were PD-L1 IHC positive and not in those who are unknown or PD-L1 IHC negative. This remains a highly controversial area, and the international community of thoracic oncology experts have published editorials contesting this decision. Additional translational studies are currently designed in ongoing prospective trials to try to clarify whether certain subpopulations of unresectable stage 3 patients do or do not benefit to consolidation durvalumab after concurrent chemoradiation. So hopefully this information will be available in the future. In closing, I'd like to thank you for listening to this week's episode of the ASCO eLearning Weekly podcast. For more information on the treatment of non-small cell lung cancer, including additional patient cases and opportunities for self-evaluation, please visit the Comprehensive eLearning Center at elearning.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.